but I will try to share some knowledge on what PNF is, but more so like why we, like how we think as a PNF therapist, rather than just teaching you guys like pattern work or like how to perform the patterns. I want you to really think like a PNF therapist, and then I'll try to apply it to orthopedic applications at the end. So it was exciting for me to put DPT finally on here, and I took my board exam Tuesday, so I was hoping to put PT on here, but I still don't know my results. So here's some pictures, beginning and then the end. We gained a few people, but it was a fun experience. Basically, focus points. I'm going to start by the history and background of what PNF is, the philosophy, pretty quick on that one, and then the basis is the basic principles of PNF, and then how to integrate it with the orthopedic setting. So PNF started as just proprioceptive, or proprioceptive neuromuscular facilitation actually just began as proprioceptive facilitation. This was in the 1940s. It was developed by Dr. Herman Cabot, and it was later termed neuromuscular proprioceptive facilitation by Dorothy Voss. Basically, Dr. Cabot just wanted a way of assessing and treating patients, but also to facilitate a better movement pattern at the same time. So he linked up with Henry Kaiser at the time, so this is like the beginning of Kaiser history as well. And Henry Kaiser's son was suffering from MS, and Dr. Cabot said, how can I help his kid? And basically Henry Kaiser said, I'll pay you anything to help my kid. And they linked together. He formed up with Maggie Knott, which was the first therapist to be hired by Dr. Cabot, and then they developed what is now known as PNF. Maggie Knott actually was at Kaiser Vallejo until pretty recently, so her influence was there for a long, long time. So she started the residency and then got to kind of see what her vision was for it. So here's the philosophy. We were taught this day one in the PNF residency. Basically, like when you're treating a patient, everyone has potential, whether it be small or big, and you just have to find what demands can be elicited on that patient to get their potential. Everyone's different, but everyone has potential. And then PNF is an integrated approach. So, I mean, this is just like what we do when we treat any patient. There's a physical, intellectual, and emotional side of treating a patient, and we have to take this into consideration. Say we're just focusing on the physical and we forget about their emotional side, they might be a little discouraged or they don't want to work with us, so we have to hit every point. And then it's a positive approach, so we always see what they can do rather than looking at their functional limitations, their disabilities, and participation limitations. We look at what they actually can do and what they bring to the table. It needs to be specific, so and this is same like with all our other therapy, it needs to be specific in how we're treating a patient, and it needs to be directed toward a specific functional goal. So like when we write our patient goals, same with PNF, we find our patient goals. Number 5 is one of the things that I really think you can take into orthopedics, and I'll talk about it later, but basically using the stronger body parts to strengthen the weak or to influence the weak. So not just focusing on the weak musculature, to actually use the strong to irradiate into the weak, and I'll talk about that later. And then we want to facilitate a maximal response. You don't want to be at this plateau for a while. We have to challenge our patients. And this is the way that they increase sensory and motor awareness, building strength, coordination, and balance. You need to repeat that maximal response in order for them to actually learn the motor skill. And then similar we're going to learn about dynamic reversal, but if you alternate the activity, it can reduce fatigue. And I'll talk about what a dynamic reversal does with actually pattern work. You need a continued activity to maintain and improve that power and coordination and actually have strength gains long term. And then the goal is ultimately optimum function. So I put this little blurb in. It's not from them, but I just said that it's a way of thinking. These principles that I'm about to teach you guys, it can be integrated into any patient treatment at any setting. I've heard people do PNF in neuro, inpatient, pediatrics, orthopedics. I mean, you probably can do it in skilled nursing. I mean, anything. They were saying inpatient setting, you can do it quite often as well. So just try to think about how I would think like a PNF therapist. So this first one, I want you guys, this is going to be kind of an interactive one because PNF is very hands-on. So the first basic principle is tactile input. So it's broken down into two categories, both patient positioning and manual contact. So patient positioning, really be keen on this because it can change your patient response. So if, say, you're setting up a patient to do abdominal curl or abdominal with the ball or something like that, and you have them in supine and they're getting extensor tone or extensor activity, that's not going to set them up for success because their reflexes and their body patient position is inhibiting that muscular response. So you need to maybe move the plinth up and actually cue the abdominals to be on first, and then give them a chance to be successful. That's just one example. And then manual contact. So I want you guys to try to break into two, partners of two, and then try doing like a wrist flexor MMT. Have the first one do a manual contact on the wrist flexors, and then I want you to change. So go ahead and try that if you're not eating. And compare the strength response. So you see, how did you guys do it? So did you wrap around the extensor surface? Were you mainly on the flexor surface, or were you kind of gripped around when you were doing it? Gripping around. So when we were taught in PNF that our manual contacts have power. So say you're trying to get just flexor activity, which is the wrist flexors, you should just only be on the flexor surface. And that actually sets the patient up for the most success on that MMT score. If you're gripping around and holding, they're getting extensor input, they're getting flexor input, so which can kind of confuse the patient. But also, if you give a kind of a grip, it can be inhibitory, so they'll actually have like a pain response from that. And that'll even cause them to be less strong at that MMT. So we use what's called a lumbrical grip, and it's basically just like your lumbrical, so that it's comfortable, but it also gives specific input. And you guys can see on this one, that's the windup for flexion AB, but you can see how right here I have a lumbrical grip, and I'm only giving feedback like a tunnel to the will be the flexors. So try not to confuse the patient. The second one is your therapist body mechanics. So this is huge for any physical therapy activity or exercise. But with PNF, we're specific on maintaining a functional spine and being in line with the desired movement. So we work in diagonals and in pattern work. So we have to make sure that we're in line with the diagonal so that the patient can actually, because we're facilitating the movement. So the patient has to be in that diagonal, and so do we. So this next one, I want you guys to stand up and try to do to where you just stand in a kind of a poor posture, and I want you to apply pressure just to the anterior acromion or the shoulder. And I want you to look at the response that you have. So you can kind of see, you can easily push them over, right? They're like jello, they have an extensor response. Now I want you to try to fix their posture, correct to what you would think would be good, engage their abdominals, and do the same thing. And they're much more solid, right? Now a lot of us, we have still a lot of extensor input, and we tend to lean back and be retropulsive, but even just the correction on the abdominals can help you as a therapist be on your toes and not being off balance when you're facilitating any exercise. Have you guys demo, but basically PNF basic principle number 3 is appropriate resistance. So when we're facilitating a movement, we want to make sure that it's appropriate for that specific patient so that it is facilitatory and not inhibitory. So say we're over resisting the patient, they're not going to be able to move at all. But if we're under resisting, they're just going to fly through the pattern work, and it's not even going to strengthen the muscles. So and this can include the PNF iso. So we break up isotonic and isometric differently than what you learn in PT school, but we break it into an intent to move and no intent to move. So you can have an isotonic, which is like an intent to move. Say you're trying to hold the patient in one spot. If you let go, they're going to move. They're fully contracting. Whereas in isometric, there's no intent to move. This is like maybe in the presence of pain, muscle guarding. It's just light resistance, and I'll go through this again, but use the cue of just match me, and don't push in too hard. And when you let go, they'll just kind of stay in place. So that would be in like the presence of pain. The basic principle number 4 is traction versus approximation. So say you're doing prone on elbows or some kind of scapular stability, and a patient's falling down, and they keep falling down, and they keep falling down. You're like, what's happening? Why can't they stabilize? You might want to try to do some approximation. So this is for stabilization. This is for muscular stability and weight-bearing activities. So what you would do is provide a manual cue to their scapula and give them input through the long axial of the humerus down through the mat, and that can actually help them stabilize that scapula until they're strong enough to do so themselves. Or maybe they're not getting enough movement, and this is when traction comes in. So this could be a patient post-op with a lot of pain, or someone who's pretty weak, and you have them in sideline, they're still not getting any activity. You could use traction, which is basically pulling up through the motion. As you can see, this is an example of traction, but it's going straight up. But I'm also doing traction here, so I'm pulling straight out into the motion of the pattern to give him help to get down and through the pattern. And then the picture on the far right is an example of approximation. So I'm about to do a shoulder scapular press for like scapular protraction, and I'm applying approximation through the scapula for him to get both feedback, but also through the humerus. The next one is we learn that there's a quick stretch stimulus that you can use, and this is not just for neuro patients; it can be for your ortho patients as well. But basically, it's an involuntary reflex. It's not infatigable. Sorry. But it needs to be maintained by resistance in order to be facilitatory. So you can't just stretch the patient and then let go. They're going to be like, there's nothing to push against. There's nothing to be facilitatory against. So say I'm winding up this patient into this pattern, and as you can see, they're completely wound up. So the goal of that pattern is to have them in internal rotation, to have the wrists flexed, and to have them protracted against and reaching for their opposite hip. But if I don't have them wound up correctly, my quick stretch is just going to be empty. And we're going to practice with a few of these in orthopedic applications, but if we don't get it wound up correctly, it's just not going to be facilitatory. But you can do it with contracting tissues as well, but I think it's a little too much to go through today. So basically, the sixth basic principle is irradiation, and I think this is one that you can take into orthopedics probably the most. And it's basically a stronger body part influencing the weaker, or like a CNS overflow into the weaker muscles. So as you can see on the left side picture, I'm actually overflowing from his upper extremity. His left upper extremity, actually upper extremity in general, is really strong, but his hip flexors are really weak on that right lower extremity. And in PNF, we learned that the body works through diagonals, so I'm going upper extremity to opposite lower extremity. I'm using a flexor upper extremity into a flexor lower extremity. So you think about, as long as I'm engaging the abdominals, then it probably is going to cause a flexion, irradiation into the lower extremity. But you can also irradiate into just the abdominals here. So I'm using an extension adduction pattern just to get into his opposite side of his abdominals. So the irradiation is traveling from his upper extremity into his abdominals here, which can be used for post-op. It can be used for people with swing phase deficits, etc. And then the last one on the right is the opposite of the first one. It's using an extension-based upper extremity pattern to get into his hip extensors. So maybe they have weak glutes, but their upper extremities are really strong, and you just can't figure out they can't do a bridge, they can't do even like a prone frog squeeze. Then maybe you can try this to get some extensor into the glutes, because you're supporting them against gravity too. Basic principle number 7 is normal timing. So every activity has a normal timing to it. We learned that, like a sit to stand, you have to do it in a correct sequence. The same thing happens with PNF, is there's a normal timing to our verbal cue, but also to what we want the patient to do. So, this isn't the greatest picture for this one, but and I'll be going through, this is a shoulder protocol, and it's something I think would be really great for orthopedic application. But basically, we go distal to proximal. So say they're going out and up to this pattern here. We start with the wrist. We don't start with the shoulder, right? So my verbal cue would be like reach up, wrist back, and pull up. And the same thing would be like with a sit to stand. We say lean forward, nose over toes, push through your quads, and then stand up, squeeze your glutes, and that, etc. So it's the same thing as orthopedics. We have a normal timing to what we want. Am I going too fast? Okay. And then this is what everyone knows what PNF is. It's the patterns of facilitation. So patterns, or commonly known as PNF patterns, basically you're placing synergistic movements into a diagonal pattern work and spiral pattern in order to get facilitatory action through the muscle. But basically, facilitation is much greater when the desired movement is performed with these diagonal patterns. So this next, I want you guys to pair up again. I want you to try, just have like a interinterosseous nerve, like an OK sign, and basically have it down here and just try to break your partner's fingers. You guys can stand up, though. It might be easier to do it that way. Sorry. Try to break it there. Okay. Okay. And then now I want you to have them go across their body, reaching for their opposite hip, go into internal rotation at your shoulder, flexion at the wrist, and have the same thing with the OK sign, and now try to break them. So this could be not only a fun bar trick, but it also has function in the physical therapy application. Is basically the synergistic movements were not in tune. The first one, we didn't have really any synergistic movements. We didn't have internal rotation at the humerus. We didn't really have flexion at the wrist. Nothing was on. But when we put them into that pattern, all the muscles were working together, and they were much stronger.
And what do you mean by if you can go back
yeah.
Quick stretch, to facilitate a quick stretch?
Yeah, so she asked, what do I mean by a quick stretch to facilitate the pattern? So basically, if you're in that diagonal pattern and all the components are wound up synergistically, you can find that there's a springiness to the muscles. There's a potential energy that's ready to go. And that's what we use our quick stretch from. So to facilitate the pattern. So basically, if you're in that diagonal pattern and all the components are wound up synergistically, you can find that there's a springiness to the muscles. There's a potential energy that's ready to go. And that's what we use our quick stretch from. So I would never quick stretch from a non-wound up component because it wouldn't be facilitatory. So that's what it means. You're welcome. Oh, I forgot to do an irradiation one. So one more thing, I'd like you to do a hip flexor MMT. Try to do it with the ankle plantar flexed first. So have the patient go up and do a hip flexor MMT like normal. And see if you can break the patient. And then the next time I want you to do it with the ankle dorsiflexed and see how much stronger you can be. So what'd you guys notice? What'd you notice? Yeah, big difference. Basically what's happening is there's not only irradiation going on, but all the muscles are working together. So when you have plantar flexion going on, you're getting basically hip extensor input, which is not going to help the hip flexor MMT. So when we teach our patients to do an MMT, we really have to be cognizant of what they're doing down below so that they're set up for success. But also when they're walking, if they're gait pattern and they're dragging their toes, we need to make sure that they're using their dorsiflexors to get into their hip flexors. And then the last one is visual and verbal input. So basically we can use visual cues, props, cones, anything you want in order to basically enhance the patient optimum function. So basically we use a lot of cones and I use my name badge and I always put it down, pull toward my name badge or something like that so that they have. So this next one I want you to see the influence of what your visual input or your eyes can do on the body. So I want you to try just sit in your chair. If you don't have a back would be preferable. And then just look up and have your partner try to push you back. But be safe about it. Okay. Now I want you to look down just with your eyes, just with the eyes themselves. And do the same thing. So what'd you guys notice? It was what? Try looking up, yeah. 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 Yeah, so it's going to be a lot stronger with your eyes down because when you're looking up, it's feeding into the extensors of your body. And you were asking them to engage their flexors. So you could see we didn't even move the body, right? We just moved the eyes. But the eyes cue the movement. So your eyes were telling me, I want to go back, while you're saying, I want you to go forward. So it was contradictory. So you have to make sure that they're actually looking the right way too. It sounds crazy, but. And then your verbal input. So when you're asking a patient to do it, you have to be specific on which patient you say, come on, push, 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 that might be inhibitory for that patient. Or you have an athlete who's high level and they want that, and that could be facilitatory. But also you could try playing around with like a preparatory cue, like say, and then give them a little pause, let their CNS, their central nervous system, kick in, and then say pull across or lift up or bridge up or push down. And you find that a lot of patients who are elderly or a little bit, they have motor processing deficits. They're going to actually benefit from this a lot instead of just saying push up, and they can't keep up. So here you guys are. So this is PNF in the orthopedic setting. So you can already see there's some already applications you've learned already to be an orthopedic setting. But these are things I think would be really beneficial to you guys in the orthopedic setting. So the first one is it's actually a technique that I learned in PNF, and it's called the hold relax. So you guys probably have done contract relax, you might have even done hold relax, but basically it's in the presence of pain, muscle guarding, limited range of motion when the patient basically doesn't want to activate the muscles. So it could be post-op shoulder, post-op knee, something like that where they don't even want to activate the muscle. So in the first picture you can see, so this is about 90 degrees of shoulder flexion. You can do it with a bent elbow if that's too much for them, but all I'm asking the patient to do is just hold here and just match me. So it's really light resistance, and I'm pushing down into extension and they're just holding up into flexion. So this would be an example. If they have tight pectorals, this is reciprocal inhibition. You can do it the opposite way. You can go into the tight muscle. So say they have limited range of motion, you can ask them to slightly pull down into the tight pectoral muscles, and that can actually release some of the tension in the muscles, and then you bring them into further range. So that would be kind of like what I'm doing in the second picture. You hold it for 8 seconds, and then you basically have them completely relax. So if they don't completely relax and you just, right after the 8 seconds starts, you just pull them into the new range, it can cause muscle guarding and more pain. So you have them completely relaxed, their central nervous system is relaxed, and then you can bring them into the range passively or actively. Yeah?
I was just curious if there was any benefit to holding longer than 8 seconds, like maybe 20 or 30 seconds.
You know, for static stretching, they say 20 to 30, but for PNF, they did a ton of research, at least what they were told me when they taught me, and 8 seconds seemed to be the most beneficial for these patients. So they played around with 15, and it wasn't any better than 8. So they found they could do more repetitions with 8 seconds and get more benefits than holding it longer. I don't know. And then we have the opposite, which is contract relax. So this is a patient with limited range of motion. They have strength, but they don't really have any they don't have any pain. So this is, your cue is pull against me, push against me. You could say as hard as you can if the patient is not going to hurt themselves. So in the first picture, I'm asking Andrew, my patient, to pull down and across as hard as he can, and he has really tight pectorals. Basically, the goal is that through contract relax, which is through the muscle spindle, that the muscles will relax. So I'll hold that for 8 seconds, and then I will let him relax completely and then bring him into a further range. And this is something I did with Mike all the time in MSI, is just a pec minor pec stretch. So you can do the same thing and integrate your contract relax here, or your hold relax. You can have him push the pecs up in, 8 seconds, relax, and then just bring him into that new range. Something I didn't do here in MSI, but I didn't know. So I didn't know that contract relax could be used in this position. And it works really well with the neuro patients as well. Stabilizing reversals. So this is for stability. So a patient, say they have not a lot of trunk control, they're maybe ataxic, or they have vestibular issues and their trunk is not stable, or anything actually. It could be their shoulder as well. You can use stabilizing reversals to hold in that position. Basically, it's alternating muscle contractions against resistance within a static posture. So you can see I'm asking Andrew in the first picture to protract against resistance, and I'm having him hold there. And then what I'm doing, once he's holding, I'm doing what you can see in the next pictures. I'm using traction up through the long axis of the humerus, just to give him a little bit of help. But the resistance is going down against his resistance. And basically, I'm asking him to hold there for stability. So this could be for scapular stability at this point. Maybe they have post-op precautions that they can't go beyond 90. and you still want to gain scapular stability, this could be a good one to get them stabilized before they go into the new range. And then you can sprinkle in contract, relax, or hold relax on top of your stabilizer reversals if they have range of motion limitations or maybe it becomes painful. So I use this one a lot with like patient in sitting who doesn't have trunk support or really good abdominal activity. And you cue them to sit up tall and you get them in the correct posture. And basically you're just going to do stabilizer reversals at the anterior acromion and at the scapula. You can do it at the pelvis as well, but I found that the scapula and the acromion worked really well. And you just get low and use traction, push them back and say hold here. And then you slowly, never move both at one time. So you hold one and then you rotate to the scapula and say hold here. And then you rotate, hold here, and then you rotate. And they have to stabilize in that position. And we found that if they have a stable core and a stable abdominal trunk to build off of, these patients were much more successful. So I had patients with ataxia, stroke, and even just post-op, and they had such weak core and trunk that they weren't able to even move efficiently or use upper extremity motions until they were able to activate the trunk first, like the TA and the obliques. So that's a key one for orthopedics as well. So then dynamic reversal. So I want you to just think of like the philosophy of what a dynamic reversal is. So we call it slow reversal, partially because we don't really want the patient to contract all their muscles as quickly as they can. We want it to be controlled and stabilized. But basically, it's a reversal of concentric contractions. So you have them go in one direction, and then you have them go in the other direction. I was thinking, like, what would I do in orthopedic setting? You could do pattern work, but it could be as simple, as like a hip flexor to hip extensor, or vice versa. So say you're trying to work on hip flexor strength, and the patient fatigues after 8 repetitions, and you're like, why do they keep fatiguing? It's probably because it's either too much or they don't have the endurance. So you can reverse the pattern, use the opposite, the antagonist muscle group, and that can cause the patient to actually have an instant CNS relaxation, but also strength into the hip flexors again. So it causes coordination strength into the opposite muscles. So it causes relaxation and also causes strength into that muscle group again. So like I was thinking also like bridging you could do. Anything you could use this philosophy of a dynamic reversal to not over fatigue your muscles and always be working on, like, say, the flexors. You can work both muscles. Or you could do like flexor activity, then extensor, flexor, extensor, flexor, extensor, and then pretty soon they're not fatiguing through the 30-minute treatment. Combination of isotonics is also a really, I think, a really beneficial one for orthopedics, because you see it all the time. So Mike and I always did an MSI, like shoulder flexion facing the wall. We had them pull up against the band, and then we had them slowly lower against the resistance. That's what a combination of isotonic is. It's an agonist contraction, so they're using their shoulder flexors, and then they're using an eccentric lowering of their shoulder flexors. The only thing we add is like a hold at the top and then a hold at the bottom, but it's something that can be beneficial for orthopedics. Combination of isotonics I use probably with every patient, only because it's for stability and for strength, and most patients need both. And I feel like orthopedics, a lot of it is like based on like the scapular stability, and I feel like this could be a key concept for you guys to learn, is just going slowly eccentric lowering. I mean, you probably already do it, but now you know what it's called. These are some exercises that I use, and I think that would be fun to learn for getting your abdominals and the trunk flexors in. So the one on the top is just a bilateral lower extremity flexion, and I use the one on the right more often. I didn't usually wind them up as the left picture showed. I usually pre-position them. So what my goal in this activity is to pre-position him in trunk flexion. So you could raise the plinth up a little bit to get them already biased into flexion. And then my goal is to get his opposite knee across midline. So you can see that his left knee is across midline onto his right side. His dorsiflexors are on, which is what we want to get hip flexor activity. And then I would prefer, he didn't do the perfect job, but I still like what he was doing as a chin tuck. So to have his chin tucked to get the further abdominal activity. And then I would just say, hold here, don't let me pull you down. You can play around with like, slowly let me lower you down a little bit, hold there and then pull back to that spot. But it's a great way of getting the abdominals on without doing crunches or like ball squeezes and that kind of stuff, using just strictly the strong upper extremity or the lower extremity. You can get the flexors on with the upper extremity. So you can see them using extension AD on the bottom left. And I'm trying to get into the opposite side of his trunk. So it's working through diagonal patterns, right? So his strong left upper extremity, I'm trying to get into his weak right lower extremity or his trunk. This could be someone, like I said, with a swing phase deficit. Their hip flexors aren't activating, but they have awesome upper extremities. So you can use that to get into their lowers. Or it could be just a warm-up for any patient. My goal is to have him pull down and across to his opposite hip. And it was similar to this trick. He's winding up into internal rotation and flexion at the wrist so that he's super strong in that position. And then this one's challenging to do, but it's a bilateral upper extremity flexion. And they're basically doing two arms of the same pattern to get into the abdominals. So this is for scapular stability. I wish I would have known this when I was working in orthopedics because I feel like it would have been really helpful. So the first one is just shoulder protraction. So it's our protocol number 1 in PNF. You can do this with straight arm, bent arm. So the lever arm is shorter. Whatever the patient can actually perform. You can do it in the scapular plane. You can do it at 30 degrees, 90 degrees, or even up to like 120. But just try to bias it to get the most out of the serratus, most likely. I like to have my positioning on the scapula so that they have something to push against. So they're getting that manual contact. I'm not wrapping around underneath to give them like a retractor feedback. I'm just staying lumbrical grip on the shoulder protractors so that they have something to push against, and then they have a closed fist to push against as well. And then you can see on the bottom right is the one with the bent arm. So the lever arm shortened. I'm still in the same position, but you notice my positioning is different. So I move from the bottom up to the top because I have to support the upper extremity, but basically the same thing. And then protocol number 2 and 3. So this is a good one, I think, for rotator cuff early on once they get out of the isometric phase and they're starting to do active motion with limited range. You could do like we call it protraction, abduction, external rotation, which you can see on the top left. And I'm using normal timing. I want him to bring his wrist back and out, but I also want him to push down. So this is an easy way to get all the combination of external rotation, protraction, and abduction at the same time. So I would cue him. I'm using a lumbrical grip on the elbow, saying, can you push down into me? So to get protraction, and then wrist back and pull out into the range that they can perform. And then the opposite, protraction, adduction, internal rotation, is the ones on the right. I'm saying, can you push down into me, squeeze my hand, and pull back in? So this is a pec exercise. It's a shoulder subscap internal rotator exercise, but it also can be used for the wrist flexors as well. And you notice my positioning, so I'm not staying stagnant. I'm moving with the motion, and I'm staying kind of in the diagonal, but also not hurting my back. So with PNF, that's where body position comes in. And then we can do it in side lying as well. So you can see that this would be harder for the external rotators because gravity is not helping him anymore. But also this is where patient positioning could be key to make sure they're not rolling back when they're doing the motion. But this is easier for the internal rotators, so you can modify it based on the positioning. So this would be easy for these guys here, but harder for the external rotators. So I think this is a great exercise for post-op shoulder. And then here's my favorite. I just think it's so cool, is the irradiation. I touched on it briefly, but you can do irradiation from an extensor upper extremity into an extensor lower extremity. And I'm going in the diagonal across the body, asking him to hold his upper body just in that position. He's not moving it. And basically what I'm asking him to do is pull this leg down, pull it down. And he's just holding the upper extremity, and you'll find that they actually get a lot stronger than just staying on just the leg. And then pretty soon we don't need to use irradiation so much, and we can just focus on the lower extremity by itself. But it's a great way to kind of progress a patient if they don't have the adequate strength to do the exercise that you want. And then you guys saw this one, upper extremity going into the flexor. So it's a flexor upper extremity activity going across the body into the lower extremity. So I was thinking this would be a cool one to do with like a post-op knee where they don't have adequate knee flexion or hip flexion. You can have them laying on their back, similar to this picture, but with their leg down on the plinth. You could have them do like their normal, like pull on this rope, right, to get the knee flexion, but you can also have them irradiate with the upper extremity while they're doing that. If they're cognitively quick like that and they can understand that, you can actually get irradiation through the hip and knee flexors to get them through that range of motion limitation. Yeah, I was thinking. And then, let's see. And then you can also use a cross-extension reflex. So in school we learned that it's kind of the reflex for walking. When one pushes down, the other one comes up. But you can do the same thing post-op. Say this is a patient with a knee injury and they don't have adequate knee extension and they're not getting quad activity, but they're too painful to touch that side. And every time you touch it, they're like, ow, don't touch me, that hurts. Or every time I contract that muscle, they focus on just that muscle and it hurts them too much. You can use the opposite side of the body to get into the opposite lower extremity. So irradiation works usually through diagonals, but it can also work through reflexes. So this is working through the cross-extensor reflex. On the one on the left, I'm just asking him to pull that leg up and across. I'm staying in a diagonal. And Andrew told me, hey, my quad feels like it's active, and I'm pushing down through that towel that you placed there, and it wasn't painful. With this one, I was saying, can you push down into my knee? So I was modifying it a little bit to see what I could get more activity out of the patient. Same thing up top, pull up and across, and then but push down into me and get extension through the quads. And then this is the last one, is irradiation from one scapula to the other. So this could be for before you do any upper extremity motion against gravity, this could be pretty low level activity, but a great one for setting the scapula. So you could start out laying in supine, you get underneath the patient's inferior angles, and you say, can you pull them down? And then say one shoulder is stronger than the other, you can say, hold that strong shoulder, let me shrug up your weaker one, and then you can irradiate from that strong shoulder and have them pull down against resistance that way. A lot of times they do have a weaker side and they have a strong side to build off of, especially if they're post-op. And this could help set the scapula if they don't have the adequate muscle activity to do it just with the right shoulder. But that is it, and I'd love to take questions and practice. And
Pauses in between?
They'd actually never talked about pausing in between or pacing with irradiation per se. But most of the time we would gauge it just like we do in orthopedic or exercise based. If they're doing something more like aerobic or endurance, we'd give them, I do it up until, like, say I want to get 10 repetitions, I just do back to back to back. But I think that would be more patient specific. Like, I don't know if there's a specific number. Like with hold relax, 8 seconds was proven to be, but with irradiation there isn't, I don't think, a specific number.
Of your continuing service and support to our department here.
Thank you, yes.
So that is for you, signed by our
Thank you.
Team,
Yes.
our administration. So thank you so much.
Thank you. It's awesome being back, by the way, and seeing you guys. Thank you. Yeah, I can do a demo whenever you guys are ready.
Yeah, I was.
So let's do the hold relax. So we'll have him lay down for me. Okay, so I might actually lay this flat. Okay. Like, how does the go up and down again? Is there? There it is. Cool. Let's see, actually, okay, so say this is his post-op shoulder, so I'll have him actually scoot over a little bit toward me. So I could do a hold relax in this range here. So my demo, I was here, here, and here. You could have him punch forward and up, hold here and do that. And a hold relax will look like this. So You have him hold. Just match me. Just match my resistance. Good. And 8. Relax. Just relax completely. You can do it without protraction, so you can just have him hold it here. Just match my resistance here.
He's going into flexion.
I'm pushing him into extension. He's going into flexion. I'm using kind of a lot of traction up through the arm there. So what do you feel, Ben? Good. And relax. So see how when he relaxes, nothing really happens as far as motion because his intent's not to move. And then you can have him completely relax and say you want to get more range. You can slowly move him into more range and then do the same thing. So match me here. You do? Yeah. So it doesn't seem like much, but there's a lot going on with scapular stability. But then, so I'm going into the tight shoulder flexors or the painful shoulder flexors. You can do it the opposite. So say they're so painful that they can't even go into flexion. You can have them kind of slowly match here, push down. Good. And relax completely. And then you can kind of bring them into more range. So that's what a hold relax would look like. Contract relax in the same position will look different. So say I'm trying to get more shoulder flexion. I would get in so I'd actually have you open up your hand here. Position him kind of in the line here. And I would say, so he's still in the same position, but I want you to squeeze my hand. Can you pull down as hard as you can? Down out toward your opposite hip. There. There you go. Pull, pull, pull. 6, 5, 4, 3, 2, 1. Relax. Good. He's going to relax completely. And then you just move him into the new range. You hold him in that range, and you have him contract again. Contract, pull down. So this would be a contract relax for, say, a tight pectoral muscle, flexors. And I'm trying to have him pull it down and across so that he uses the diagonals. You can do it going the opposite way too. So I could switch positions, have him open his hand up, and just pull up. Pull up as hard as you can, up and overhead. Up and over. Yeah, there you go. Just hold there. So I'm kind of pulling down and across the body in a diagonal. And then you just have him relax completely. And then slowly bring him into more range. This one probably would be more painful. But if they don't have any pain and they're just stiff, then contract relax is an awesome one to do. Just for demo purpose, I want to show like what happens like his intent to move. So go ahead and pull across to your opposite hip there. Pull, pull, pull as hard as you can there. Good. Nah, not that hard. I'm just kidding. Right there. Good, good, good. And if I let go, he moves, right? With a hold relax, make a fist for me. Good. Pushing him up like this, just match me. Good, and relax. Now let go. The only thing taking him is gravity, right? So you see the difference in tempo and the amount of contraction that way.
So when you're doing contract relax, do you have to go into the entire upper extremity synergy or the limb synergy? Or
You don't have to. So it's like we did it with PNF because we know that like the muscles work in synergy better, but you could do it in any position and take this philosophy and use it. You can use it with like ankle dorsiflexors specifically, plantar flexors, hips, anything. You can use the principle of contract relax.
you can do just specific to that joint?
Oh yeah. Yeah, so like say if I want to get more dorsiflexion range. So if his tight muscles are his plantar flexors, right? You can just position him here and say, can you push down into me? Push down, push down, push down, push down. Hold it for 8, relax completely, and then stretch him. So you can use it just on isolated joints too. That's a good question. And then you could do the same thing with a hold relax on an isolated joint. If they have a yeah. It's just we even just do this too. Sometimes we have to address like the muscular imbalances in itself, but yeah. And then a dynamic reversal in PNF would look like this. So go ahead and open your hand for me. Good. Squeeze my hand here. So let me get actually this up a little bit. Okay. So I would wind him up. So he actually has more tension here than most people. Right about there is where I would take him. And then I would say squeeze my hand and pull down to your opposite hip. Go, 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 go. And then wrist up, pull back. Oh. So I would actually, so then we'd use something called rhythmic initiation where I say, okay, I want you to bring your wrist up. Good. I want you to pull up to here. Okay. Then you're going to squeeze my hand, pull down to your opposite hip. Good. Wrist up. Good. Pull down. Like that. So this is a reversal of agonist muscle groups concentrically. But say my goal would be to strengthen his flexors. I'm still strengthening his flexors, but giving him an intermittent break. But you could do the same thing with like a hip flexor activity. You could do like a pulling up, and then push down to a bridge. Pull up, push down to a bridge. That kind of stuff would be like an orthopedic spin-off on a dynamic reversal.
And with that, could you use your visual too?
Definitely. So, thank you. So usually I cue them to do a chin tuck and then look down toward their hand. So bring your head up, and that'll get the trunk on even more. So say they're looking back, they're not going to have their trunk engaged as much. Yeah. And then when they're pulling their arm up, you say, wrist back, can you look back for your hand? And it gets the extensors in more. Thank you, Sean. Let's do stabilizing reversal and sitting, just for, so go ahead and sit. Go ahead and scoot forward for me, Ben. Let's see if we have it. Just a tiny bit more. So say they have trunk instability and postural deficits, or maybe they just can't figure out the anterior pelvic tilt and how to stabilize it, and they keep slouching. You could do like an NDT and say, okay, I want you to sit up tall. Good. Get the anterior pelvic tilt. Stabilize here. Relax shoulders here. Good. I want you to stay. So I want him to stay in this position, right, and not to get out of this position. So the feet are plantigrade the way I want, and I want him to stabilize. So you could use a stabilizer reversal, like I was saying, at the trunk. So I'm going to use traction, but you can do approximation too. But I would say hold here, Ben. Don't let me push you. I actually would have this a little higher for my own body. Good. Okay, hold here. Don't let me push you. So I'm using traction and pulling up through the. Good. Don't let me push you backwards. Good. Hold there. Hold. Don't let me pull you forward. Good. Hold. Hold. Good. Don't let me pull you forward here. So see how I'm rotating one at a time, going slow, not rushing it. Good. Don't let me twist you this way. Good. And relax. Very nice. What'd you feel there? Through your trunk, right? And it feels like, oh, I'm not doing much because I'm just staying in place, but that could be like a sensory cue, right? Right. Right. And then like say they're really like retropulse and they're always leaning back. You don't have to do this cue. It might feed in with, because your manual contact's feeding into extension. You could really just focus on just this. Flex forward, don't let me push you back. And that's always cueing in the abdominals. You could say look down, bring your eyes down. Use your visual cue and the power of the eyes too. So that's like it's just a sitting stabilizing reversal, but you could do the same thing with the shoulder and say hold. Okay, and then flip to the other side, hold, and hold. And then a combination of isotonics. I wanted to actually make a mention of this and I forgot. Go ahead and lay back on your back there. Thank you for being my patient. So say you're working on, it could be like shoulder elevation, but I'll show you guys what combination of isotonics looks like. I forgot to mention that you can do it with like limited range too. So it's not always go all the way up, come all the way down, hold, go all the way up, come all the way down. You can pick a specific range that maybe the movement fault happens. So like say they start anteriorly tipping at the scapula, at eccentric at the very top. So you do a combination of isotonics just at the top to get this stability. So it could look like this. So I'd wind them up, same thing. This is PNF style, but you can integrate it anyway. So I want you to squeeze my hand and pull down. Good. Hold it there. Good. Now pull up. Wrist up, go. Oh, messed up actually. Repeat. Okay, so it's actually pull it down. Good. Now slowly let me bring you up. So this is a combination. I was doing dynamic reversal. So this is a combination of isotonics. I'm slowly using the same muscle group. His flexors are staying on. Now hold it there, Ben. Hold it. Now pull back down to that spot. Okay? Hold there. Slowly let me bring you back up. Hold there. Now pull back down, all the way down. Good. Now what do you feel on that one? So it's burning, right? Yeah. So his flexors were always on, whether it be eccentric or concentric, but he never got a break, right? So that one's like one where you're gonna like tire out the patient, but it's a good one. You could do, like say they're doing a wall slide and they're here, you can have them lower down, hold it there before it wings, and then come back up. And then go back down before it wings and then come back up. And then just keep repeating it to get the muscle memory and the motor control. And then get stability that way. The bilateral lower, so say, is it okay if your shoes up? Yeah. Yeah, come on, Garrett. Come on, Western U, let's go. Lay down this way, yeah. Thanks, bud. And then, is it okay if I take your shoes off? Nice shoes, looking good, bud. So we would even probably take the socks off too, but for this purposes, it's okay. So this is like a bilateral upper extremity lower. So I would bias him. So I'd actually have you scoot up a little bit more this way, bud. There you go. Okay. So that I can bias not just his neck, but his whole trunk into flexion. So I'm already getting his abdominals on. I saw so many people doing the ball across, push in, isometric, similar to that. But we're going to have him flex up here. You can kind of hop up on the table. So you want his dorsiflexors on. And then the goal is, so say I'm trying to get this side of his trunk on. I can bias him into that position. I was saying that you want his opposite knee to cross midline, right? So right there, he's crossed midline. He's getting internal rotation on this hip and external rotation on this hip, right? But he's also getting trunk shortening on the left. So you can do like a combination of isotonics in this position. Hold here, Garrett. Don't let me pull you down. Okay. Now slowly let me lower you down. Hold there. And I want you to look for your heels this time too. Pull them up back up to that spot. Go, go, go. Look for your heels. Good. Hold it there. And I'm kind of rotating through. I'm not just pulling straight down. I'm rotating back to the beginning of the pattern. You could do this with pretty low-level patients, and they can get great results. What do you feel on that side here? Working, yeah. But even more when he looks for his heels, too. So you can even have him kind of bend over and look for him, not rotate out, but just to get the flexors on more. Okay, hold there. Good. Versus try doing it when you're looking up. Right? So no strength. Just kidding. You got a lot of strength. So that's something that you could do for getting the flexors on. Am I out of time? Almost out of time. And then we can quickly do the shoulder protocol. So this one, you could have them down at the bottom. So the first one was just protraction. Make a fist for me. And then scapular grip, and you can just have them push up against resistance and just hold. You can throw in stabilizing reversals here for stability. So he could hold it up, and you can throw in stabilizing reversals. Hold here, keep holding. You can throw in combination of isotonics. So say it's just the scapula, you can say push up into me. Okay, hold there. Slowly lower your shoulder back down. Hold there, and push it back up. Like that. Using the shoulder protocol number 1. You could do it with the elbow bent, so kind of with a cradle. Give him kind of a lumbrical grip here, so you're not grabbing the other surface here. And you can use the same here. So push up into me. Good. And then what you can do is like a reversal with the external rotators and internal rotators using your body. So you can kind of lean out. So don't let me move you. And he's getting his internal rotators on because he's pushing into my forearm, right? And then I lean into him and say, don't let me move you in. And now he's getting his external rotators in with stability at the scapula. And then the last one was the number 2. So you use a lumbrical grip here to get just the protractors here, protractors. And then you're on the extensor surface, lumbrical grip, so that he gets his extensor feedback. So you'd have him push down into me. Right, there you go. So you don't want down, you want protraction, right? And then you'd first have him stabilize. Don't let me push you in. Good. Now can you bring your wrist back? Just bring your wrist back. There you go, there you go. Good, and then pull on out. So this is too low of a table for me, but you get the point. Just like this. So he's pushing down, wrist back, and pulling out, stabilizing here. And then the opposite is you would switch your hands, because I can't get onto the flexor surface with this hand. It would be awkward. So you switch your hands. You have them push out, and then just pull on in. So squeeze my hand, pull on in. Good. And then you repeat it. So push down and pull on in. Good. Push down into me and then pull on in. You can get more resistance, like I can push into him there, make him work. Or that's like more of an approximation, or I can have him push in and I can give him lots of traction. Really easy. Push in, pull on, and you're pulling him kind of through the range. And then progress him through more resistance here. Whatever the patient needs. Yeah. I think, unfortunately, I'm out of time, but thank you guys for listening to me.